Yeah, in the last lectures, we have discussed about childhood musculoskeletal conditions. We have discussed about this developmental dysplasia of the hip, in which acetabulum will become very shallow, and as a result, the dislocation of this bone occurs, of this joint occur, right? And it is mostly seen in the patients with the beach presentations, right? And it results in the hip instability and the dislocations. And we have also discussed that how X-ray is not helpful in diagnosing this condition, because it takes time for the ossification, up to 6 months, right? So even if you do the X-ray, it won't show anything. You need to do the ultrasound to confirm this disorder. And for the lac purchase disease, we have discussed about that the patient presented with the limping, and it is insidious in onset, idiopathic, right? And it is the avascular necrosis of the femoral head. X-ray is also normal, and the changes will be visible only after the 6 weeks. Okay. Then the osteoscatter disease, in which you're having the avulsion fracture of the tibia, right? And as a result, you will have a very weak extension of the knee joint, right? And it is mostly seen in the athletes or the jumping athletes, I must say, like the ones with the basketball playing, right? And it is seen generally in the teenage patients with the growth spurt, okay? And that's how, this pressure on the tibial tuberosity and the patellar tendon is very much increased, and as a result, this avulsion fracture occur, right? Then the patelliform syndrome, which is seen only in the females, right? And it generally presents you with the pain, okay, and that occurs with the knee flexion, okay. Then the radial head subluxation, okay, also known as a nursemaid elbow, seen in the child, after sudden pulling of the arm, right? And it generally happens to prevent the child from falling and something like that. And what happens is this annular ligament, which is a ligament between the radius and the ulna, okay, it comes between the humerus and the and this radius, right? It slipped between the humerus and the radius, and as a result, the patient will have a slightly flexed elbow against the abdomen, right? And then the slip capitis femoral epiphysis syndrome, which is seen in the obese obese teens, right? And that would be all about that. And the dupin contracture, we have discussed all scenarios here. We have discussed up to the achondroplasia part, right? In which it is an autosomal dominant condition, okay? And it is because of the mutations. Activation mutation is very important. Activation mutations in the fibroblast growth factor 3, and as a result, the chondrocytes are inhibited. Okay, you don't have any cartilaginous bone growth model, and as a result, your appendicular skeleton and some part of the axial skeleton also, okay, it won't be formed properly. You will have a short structure. Okay, the growth will be inhibited. Okay, now let's discuss about the osteoporosis. Okay, osteoporosis is like a age-related conditions mainly. Okay, and it is basically it happens whenever the bone resorption is increased and the bone formation is decreased. Okay, when the resorption is more than the bone formation, you are actually having a loss of this bone mass, and because of this loss of bone mass, your bone will become very weak and very prone to the fracture, right? And that causes the osteoporosis. So what are the risk factors for the osteoporosis? The highest risk factors is the age. Okay, it is seen in the postmenopausal females and old age males. Gender is a second important thing. Females are more prone to osteoporosis than the males. Then ethnicity is also very important. Okay, sometimes and then comes the family history. Okay, so these four are the most important factors for the osteoporosis. Okay, very important. Other risk factors, they could be secondary to the steroids. Okay, certain alcohols, anticonvulsant therapy, anticoagulants, thyroid replacement therapy. You guys know, whenever you give the patient thyroid replacement or they abuse this drug for the weight loss, then it can lead to the hyperthyroidism. And you guys know, whenever you have a high level of thyroid, it causes the bone resorption, not the bone formation, right? So the thyroid replacement therapy is also a risk factor for the osteoporosis. Smoking is a very least factor for the osteoporosis. So whenever a step one question mentioned this smoking in any of the option, you can easily neglect it, because smoking can never be the answer to the osteoporosis, right? You have far much more important risk factors for the osteoporosis than the smoking. The smoking is the least one, okay? You can have an early age osteoporosis in case of the glucocorticoid therapy or the steroid therapy, because it causes the bone resorption by activating the osteoclast cells and inhibiting the osteoblast cells, right? You can have the osteoporosis in the hyperparathyroidism also, okay? And in the hyperthyroidism, we have discussed that in the multiple myeloma, malabsorption syndromes, anorexia, right? And certain tumors also, you can have this bone resorption. You guys know that already. Okay, so all these are the risk factors for the osteoporosis. Now, there's a difference between the age-related osteoporosis and the osteoporosis secondary to these risk factors, which is in case of age-related osteoporosis, initially you will be having a trabecular bone resorption. Okay, and then in the later stages of the disease, you will be having a cortical bone resorption. Okay, so the bone resorption in case of age-related osteoporosis, it starts with the center of the bone, with the trabecular part of the bone. Okay, and then it progresses to the cortical bone. Okay, so what you can see is the trabecular thinning of the bones. Okay, and loss of the interconnecting bridges. When you do the biopsy of the bone of osteoporosis, this patient, what you will find is a trabecular thinning of the bone as well as a loss of interconnecting bridges. With the continuing of the disease, you will have the cortical bone resorption also. Okay, and in the later stages, you will see both the cortical as well as a trabecular thinning. While in other causes, okay, like in case of drugs or the hyperparathyroidism, initially you will be having a cortical bone thinning. Okay, you guys already know that. If you guys remember from the hyperparathyroidism chapter, with that part we have discussed about this brown tumor, right?
Yes.
Okay, so initially you will be having a cortical bone thinning, and when the disease progresses, you will be having a this trabecular bone thinning. Okay, so it is kind of opposite. Okay, so whenever a question is mentioned about the trabecular or spongy bone thinning, it is always be a case of age-related osteoporosis. Whenever they mention about this the cortical bone thinning, okay, or just give me a second, a subperiosteal bone thinning, you will always think about other causes, other secondary causes like the chronic kidney failure or the hyperparathyroidism or the hyperthyroidism or other cases, right? So it depends. Any doubt up to this part so far?
No, thank you.
Also, in case of age-related osteoporosis, you will be having a normal level of calcium and normal level of phosphate in the serum. While in other conditions, like secondary to the steroids or this hyperparathyroidism, you will be having a high level of calcium in the blood and low level of calcium in the bone, of course, right? In case of hyperparathyroidism, you're having a low level of phosphate and high level of calcium. Okay, so look for the lab values, look for the X-ray, look for this biopsy of the patient to determine whether she's or he's having a age-related osteoporosis or he's having a just osteoporosis secondary to these drugs, right? And you should also know about the medications that can cause the osteoporotic fractures. The first one are the anticonvulsant drugs, and they increase the activity of cytochrome P450, and as a result, the vitamin D metabolism is increased. And when the vitamin D metabolism is increased, you will be having a low level of vitamin D, low activity of vitamin D, and as a result, low calcium levels and other things, right? Similarly, the other drugs are these aromatase inhibitors, which decreases the estrogen formation in the body, and as a result, the formation of bone, or I can say the stimulation of the osteoblast cells, are also inhibited, right? Second is the methoxyprogesterone, which also decreases the estrogen levels. Similarly, you can have a bone resorption. Okay, then the GnRH analogs. Okay, if you remember, if you give the continuous therapy, okay, a continuous stimulation of these drugs, then you can have a suppression of the hypothalamus pituitary gonadal axis, right? And as a result, you will be having a low level of estrogen and the testosterone. If you give a pulsatile infusions, then you will have a high level of estrogen and testosterone. If you give a continuous infusions of these drugs, then you can have an inhibition of this GnRH, right? Then the PPI therapy, if you guys remember from the GI section, if you give the patient PPI, then alkaline medium will prevent the calcium absorption, right? So you can have a loss of calcium in the stools, in the GI tract. In case of glucocorticoids, they will increase the activation of the osteoclast cells and inhibit the osteoblast cells, as well as they decreases the intestinal calcium absorption. So you can see these glucocorticoids are the pure osteoporotic drugs, right? Very important to note. In the patients with the osteoporosis, they will be having a high osteoclast activity, high rank ligand, and decreased osteoblast activity, right? And as a result, this bone resorption is much more higher than the bone formation. Because of the bone resorption, okay, and you should also, the most common location of the osteoporotic fracture is the spine. You will have a compression fracture because of the osteoporosis. And what findings you can get on the spine is the central expansion of the intervertebral disc, because the mass of the central part of the bone, of the trabecular bone, is now decreased. Okay, the expansion of this intervertebral disc will happen. Okay, and that you can easily see. Okay, so these findings you will get on the X-ray. Now, other things that you can do for diagnosing of this osteoporosis is the DEXA scan. Okay, and that scan with a score of less than minus 2.5. Okay, it means you're having a osteoporosis and a very much prone to rupture of the I'm sorry about that. I lost my internet connection, but now it's okay. Am I audible now?
Yes.
Okay. So the first thing you can do is the X-ray. Okay. Next thing you can do is the DEXA scan. And when the DEXA scan show a score of less than minus 2.5, that means the patient is having a osteoporosis. Other hints that you can look for the exam is basically a fracture with a very minor trauma. Okay, like falling from a standing height. Okay, or like from a slight jerk, the patient is having this fracture, right? So look for these kind of hints whenever a patient has a very minor trauma, okay, that cannot cause anything. And but in this case, the patient is having a fracture because of that kind of trauma. That means she or he's having this osteoporosis. Okay, so look for that kind of hints. Okay, screening is recommended for the women of age more than 65 years. Okay, very important. So these are all the diagnostic things you can do for the patient, right? And now, what is a prophylaxis therapies? Prophylaxis therapies includes a regular weight bearing exercises, like a regular walking. Okay, very important. And it should be done throughout the adulthood also, right? And if the patient is having an osteoporotic fracture, because these are the prophylaxis therapy, the patient still do not have as the have any history of the fracture yet, right? You just want to prevent this condition. When this condition occurred, when the osteoporosis occurred, then what you can do is give the patient biphosphonate therapy, first line. Okay, you can give the patient teriparatide, which is activator of the osteoblast. It is actually a agonist of the OPG. Sorry, not the OPG, but the parathyroid hormone. Okay, it is a agonist of the parathyroid hormone. Okay, and when we give this drug in the pulsatile infusions, and and at a very low concentration, it can promote the bone growth by activating the osteoblast, just like the parathyroid hormone, if you guys remember. Then the SCRMs are also given. And does anyone remember the name?
Raloxifene.
Raloxifene. Okay, tamoxifen for the breast cancer and raloxifene for the osteoporosis. Calcitonin therapies can also be given. Denosumab, which is a rank ligand uh, monoclonal antibody. Okay, you can also given that. And so these are all the treatment for the osteoporosis. So we have discussed what the osteoporosis is. It is basically a loss of bone mass, and the bone mass loss occurs from the center or the trabecular first, and then to the cortex, right? We have discussed all the causes. Okay, and what lab values you can expect in the causes, right? You can have a loss of normal values or disruption of the values in case of secondary causes. In case of primary causes, everything would be normal, right? We have discussed how you can diagnose this condition, what screening you should give, what prophylaxis you could give, and what treatment you could give, right? And you should also know about this vertebral compression fracture, which is most commonly happen in the osteoporosis because of weakening of your spine. Okay, with a slight jerk or slight trauma, you can have a compression of this spine in between two spines, right? So it is known as a compression fractures. As you can see, this is what it look like, and you can see there's an expansion of this, the intervertebral disc here, as you can see that, right? You will have an acute pain, loss of height, and the kyphosis could be there, right? So that's everything about the osteoporosis. Any doubts so far?
I have one question.
Yeah, to ask.
If the like vertebra is getting collapsed, can we get neurological complications as well?
Yeah, of course. If the
Okay.
nerves are compressed, then you can get them also, no doubt.
Okay. Got it. Thank you.
Yeah. Any more doubt on this page?
How does hyperthyroidism cause osteoporosis?
We have discussed in the endocrine section, I think. I've told you
Okay.
about that at the very low, at a very low levels. Okay, this thyroid is actually promote the bone growth. If you guys remember, right? It promotes the bone growth, but at high levels, it will activate the osteoclast cells to cause the bone resorption. But the calcium levels, again, in case of hyperthyroidism, will be normal because of loss of this PTH hormone and increased excretion of the calcium from the kidneys, right? So you will get a normal calcium level with a bone resorption in case of hyperthyroidism.
Okay, thank you.
Okay. With a normal thyroid level, you will have a bone formation. With a high thyroid level, you will have a bone resorption, just like the PTH.
Okay, okay, thank you.
Okay, after the osteoporosis, you have the osteopetrosis. In case of osteoporosis, the bone resorption is kind of failed. Okay, you will have a failure of the bone resorption. And as a result, why is this happening? Because of a defective osteoclast. Okay, because of defective osteoclast, you will be having a failure of normal bone resorption. As a result, the bone mass will be increased too much. Okay, that will make the bone even more fragile for the fracture, right? Okay, so why it's happening? Because of the mutations in the carbonic anhydrase, and this carbonic anhydrase is very important for the acidic medium. Yeah. Any doubt? Any doubt? Okay, see, this carbonic anhydrase is responsible for the generation of this acidic medium in the body, so that these osteoclast cells can function. If the mutations happen, in this case, acidic environment cannot be generated for the osteoclast cells, and as a result, osteoclast cells cannot cause the bone resorption. As a result, you can see you will have a diffuse increase in mass of the bone. So you guys know that in case of this osteitis deformans, also known as a Paget's disease, you will be having an increased bone formation than the bone resorption in the later stages, right? When the osteoblast activity will become too much, right?
Yeah.
And in case of this osteopetrosis, also you're having this bone formation too much than the bone resorption. So what is the difference between the osteoporosis and the the Paget's disease and the osteopetrosis? If both are having this bone formation, then what is the difference? Clinically, I'm asking, not the pathology behind them, but the clinically how you can differentiate between the osteopetrosis and the Paget's disease. In both of them, you will get an increased bone mass.
Paget's disease will also be having bony deformities, like the skull shape will change and such thing.
That all things you can see in the osteopetrosis also.
Do you get the extra vascular blood vessels and
Okay, yeah, that could be okay.
Yeah,
That could be a symptom.
ALP levels. ALP levels are highly elevated in Paget's disease.
Okay, that could be another hint. Any other? A very important thing that you're missing between these two. See, the osteopetrosis is a diffuse symmetric sclerosis. It is a diffuse disease that involves every bone in your body, your spines, your hips, your femur, your tibia, fibula, every bone. But this, the Paget's disease is a localized disease. Okay, it is happening to one bone and even a part of that bone only, not a diffuse bone. Okay,
Okay.
so the osteopetrosis is a diffuse disorder, but the Paget's disease is a localized disease that is happening to a part of the bone, not a complete bone even, right? Although multiple bones could be affected, one or two, but that's just a part again, not a diffuse type. Okay, as you can see on this X-ray, you're having these two hips, and this disease is a kind of very symmetric. As you can see, both the bones are affected, right?
Yes.
Okay, so do remember this fact that it is a diffuse disorder, but the Paget's disease is a localized disorder. Okay, because of this overgrowth, okay, this overgrowth will become too much that it even involves the bone marrow. Okay, this cortical bones will also fill the bone marrow space, and as a result, you will have a bone marrow failure, and that is another hint you can get. Okay, the patient will be having a pancytopenia. He will be having a bleeding complications. He will be having a prone to infections. Anemia would be there. Fatigue would be there. Jaundice would be there, right? So these are the another hint for the osteopetrosis. So a pancytopenia, okay, along with the fractures and the diffuse sclerosis. Now, because of this bone marrow space being filled with the cortical bone, all of the these progenitor cells will leave the bone marrow and go to the extramedullary spaces like the liver and the spleen. Okay, and now the formation of your blood cells will happen there, and as a result, you can also get the hepatosplenomegaly in case of osteopetrosis. Another hint. Okay, the hepatosplenomegaly, pancytopenia, a diffuse bone sclerosis. Okay, and because of that, the patient can also have the nerve impingements, right, due to a narrow foraminals. Okay, the space where your nerves exit the spine will become very narrow, and as a result, the impingement occur that can lead to the radiculopathy also. Okay, so a radiculopathy, the cranial nerve impingements can also happen, pancytopenia, fractures. These are all for the osteopetrosis. What treatment you can give? You can give the patient bone marrow transplant, because you guys know that the osteoclast cells are nothing but the macrophages. Okay, and they're derived from the monocytes. So with the bone marrow transplant, you can give the patient monocytes, and so that you can give the patient macrophages and the osteoclast cells also, right? And when you do the biopsy of the patient, you will have an accumulation of the woven bone, and you guys already know that the woven bone is a very weak type of bone, right? It is not a strong bone, so it is very prone to fracture, right? If it become this lamellar bone, then some kind of a strength could be given, but the woven bone is a very weak bone, okay, which is very much fragile to fracture, right?
Yes.
So any doubt on the osteopetrosis?
No, thank you.
Okay. Then comes the osteomalacia, also known as rickets. It is due to a defective mineralization of the osteoid. Okay. See, first you have the osteoid, okay, which is a kind of a collagen part, okay, organic part of the bone. Then over that osteoid, the calcium and phosphates will get deposit, okay, to form a proper bone, uh, to cause this ossification of the bone, right? But if the calcium and the phosphate are not available, okay, then the mineralization of this osteoid will not happen with the calcium and phosphate, and as a result, what will happen is the osteomalacia. Okay, it happens because of the mostly because of the vitamin D deficiency. Okay, and as a result of vitamin D deficiency, you will be having a decreased absorption of the calcium and the phosphate, right? And that can lead to the rickets. There's an X-linked dominant disorder also, if you guys remember. X-linked dominant disease, remember from the biochem lectures? Hypophosphatemic rickets, right?
Yeah, yeah.
Okay, do remember that. Okay, you can also have the rickets with the hypophosphatemia, and it is a X-linked dominant disorder, hypophosphatemic rickets, in which you have a low levels of the phosphate, and as a result, the mineralization is inhibited, right? So, what you can get is a very just give me a second. Okay, so what you can get in the patient is a excessive unmineralized bone, or I can say excessive unmineralized osteoid. Step one can ask you this fact: what you can expect in a patients with the osteomalacia. So it is a presence of or the accumulation of the unmineralized osteoid. okay, because the osteoid is not being dismineralized by the calcium and phosphate, so it will become very excessive or accumulate in your body. Okay, so what are the X-ray findings? First of all, you will see the osteopenia, okay, and so that the fractures rate will very much increase in the patient, right? If it is a child, then you can get the epiphyseal widening and the metaphasial cupping and the fraying in the rickets, okay, very important to this epiphyseal widening and the metaphasial this cupping will be seen, okay. Then the bowing of the femur and tibia will also be seen, okay, which is known as genu. Okay, and you will also have the frontal bossing, okay. You will have a soft skull, which is known as a craniotabes, okay. And just give me a second. And when the baby will sit uh, uh, you know on this bed, okay, so their head will even get flat because of the pressure, right? So their skull will become very soft because, right, and their skull is soft, so whenever the baby sleep, okay, so their head can become even the flat because of that. So this is the soft skull or the craniotabes. Okay. Patient will also have the hypertrophy of the costochondral junction, and this hypertrophy will appear as the rickety rosary. Okay. It is a bead-like appearance of the costochondral junction that happens because of the hypertrophy of this junction, right? So this is a rickety rosary. So a patient with a bone pain, are prone to fracture, having a bowing legs, frontal bossing, rickety rosary, okay, epiphyseal widening, metaphasial cupping, okay, and a soft skull. These are all the symptoms of the rickets in the infants. Now, not just the infants, the rickets can also affect the adults. And because of low level of calcium, low level of phosphate, high level of parathyroid secondary to the low level of calcium, right? You can have the bone resorption because the function of the parathyroid hormone is to maintain the normal calcium level in the blood. So it will cause the bone resorption, and what patients can have is the bone pain and the osteoporosis again. Okay, so these are the symptoms for the osteomalacia in the adults. They will always present you with the bone pain and a history of fractures, right? So yeah, what are the labs you can get because of low level of vitamin D? Low level of calcium would be there, high level of parathyroid hormone would be there, and low level of phosphate would be there. Okay, and the activity of the osteoblast cells will be very much increased, but they do not have any calcium, they do not have any phosphate to cause the mineralization of the bone, right? So you will have a high level of alkaline phosphate, and these are the marker for the activity of osteoblast cells. Okay, and yeah, it is just a compensatory mechanism for the by the body. Okay, any doubt?
No, thank you.
So that's about the osteomalacia or the rickets. Then comes the osteitis deformans, which is also known as the Paget's disease of the bone. Okay, it is a localized disorder of the bone remodeling. See the localized, while the osteopetrosis is the diffuse. Okay, in the it has three stages. In the first stage, you will be having a high level of activity of the osteoclast cells. Okay, and as a result, the bone resorption will become very too much, right? And then the osteoblast cells will become activate, okay, and they start forming the bone. So in the stage 2, you will be having a simultaneous bone resorption and simultaneous bone formation. Now comes the stage 3, when the osteoblast cell activity will become too much. Okay, it overcome the activity of osteoclast cells. As a result, you will be having a too much bone formation. Okay, and whenever you diagnose the patient with the osteitis deformans, they will be in the stage 3 of the disease also, almost always, because the symptoms of this osteitis deformans, it only present in the stage 3, not in the stage 1, not in the stage 2. Okay, so generally whenever you encounter the patients with the Paget's disease, they're already in the stage 3. And in the stage 3, it means they're having a high activity of osteoblast and a low level activity of the osteoclast cells. What labs you can expect? Okay, you will have the serum calcium, serum phosphorus, and the PTH levels absolutely normal. but you're only having a high level of alkaline phosphate, which shows that the patient is having a high level activity of the osteoblast cells. So whenever you encounter a patient with the labs that show only the high level of alkaline phosphate, right, and rest all other levels are normal, that means he or she is having the Paget's disease of the bone, right? What symptoms they can present you with because of the formation of this bone, right? They will be having a bone pain, first thing. Okay, sometimes because of this too much formation uh, of this bone, the bone will become very much fragile. Okay, and they will get fractures. You will have the micro fractures or the chalk stick fractures. Okay, that again causes the bone pain to the patient, right? Sometimes the AV shunt formation can also occur in the patient in these areas of the bone formation, like say the femur, for example. If I'm having this the Paget's disease of the femur, okay, then the AV fistula can create in the femur, and that can cause a high heart rate, okay, and a fall in the BP of the patient, right? And because of the bone formation and because of this increase in the blood flow to that area, patient can have a warmth over this area, over the area where the Paget's disease is present, okay, the area where the disease is involved. You can have a warmth over that area as well as a tenderness over that area, right? Because of this AV fistula, patient can have a high output cardiac failure also. Okay, so they can present you with the dilated cardiomyopathy and a high output cardiac failure. When you do the X-ray of the patient of that area, what it will show is the enlarged bone with the cortical thickening. You will see the enlarged bone with the cortical thickening. The patient can also get a mixed lytic and the blastic type of lesions. Because you guys know, initially the patient having a costoclastic activity and then the bone formation occurred. Okay, what you can find in the X-ray is the both lytic as well as the sclerotic lesions of the bone. Sclerosis means the bone formation, right? The bone thickening. So both the bone resorption, the lytic lesions, as well as the bone formation, bone thickening, or the sclerotic lesions will be seen on the X-ray. When you do the biopsy of the patient over that area, what you can get is the mosaic pattern of the woven bone. Okay, because you're having a too much of the bone formation and there's a defective type, you won't have the lamellar bone, it's just a woven bone is there, right? Some some level of lamellar bone is also there, but mostly it is a woven bone, and you're having a mosaic pattern or very disorganized pattern of this woven bone. Okay, and a focal thickening of the trabecular and the cortical bone would be there. Is that okay up to this part?
Yeah.
Okay, so do remember the Paget's disease is a localized bone disorder in which you have too much of the bone formation than the bone resorption. It is a localized thing. All lab values are normal, but just a high level of alkaline phosphate will be seen. On the X-ray, you will see the cortical and the this medullary thickening of the bone, as well as the mosaic pattern of this woven bone on the histology of the patient, on the biopsy of the patient. You will be having a mixed lytic as well as a sclerotic lesions on the X-ray, right? Now, because of this increase in the bone size, if the spines are involved, then you can even have the this nerve compression also. A radiculopathy could be there, right? When this the Paget's disease involves the head, patient can give you a symptoms or a history of increase in the head size, okay, which means increase in the skull size. Okay, if this disease involves the ear, patient can also have the hearing loss, okay, because of compression or the narrowing of the auditory foramens, okay. And similarly, if other areas are involved, the patient can have a bone pain, warmth over that area, right? And yeah, the nerve impingements can also be happen, right? Very important. So stages are the lytic, mixed, and the sclerotic, okay. And because of these three stages, you will get the mixed lytic as well as the sclerotic lesions on the X-ray, right? Treatment include the biphosphonates, okay. And because why you're giving the biphosphonates to the patient, can anyone tell me?
To reduce the risk of fracture.
Uh, and how does this can help in this disease? You don't want to prevent the symptoms, you want to prevent the disease, right? So how this biphosphonates can prevent my disease? See, the first phase in the Paget's disease is the lytic phase. All this disorder which is happening, it is because of the high activity of the osteoclast. Okay, only in the response to these osteoclasts, the osteoblast will become activated and can cause a disease, right? So if the high activity of osteoclast won't be there, then high activity of osteoblast is also not there. Will not be
Yeah.
there, right? And as a result, you can prevent this disease. The biphosphonate therapy can inhibit the osteoclast activity, right?
Yes.
Okay, and because of that, you can prevent the disease. So biphosphonates are the treatment for the Paget's disease because they can inhibit these osteoclast cells so that the bone resorption in a very early disease can be inhibited, right? And what you can see on the histology, one thing is the woven bone formation, which is a mosaic pattern of the woven bone. When you look for these osteoclast cells, they are kind of very very disturbed type. Okay, they have up to this 5 or 10 nuclei in them. Okay, and whenever you see that, that means the patient is having a high activity of the osteoclast cells, because you know that the osteoclast cells are a multinucleated giant cells, right? In case of this Paget's disease, the osteoclast cells can have up to 100 nuclei. It is very important. So whenever a step one give you a certain patient, and on the biopsy of that patient, you will be seeing some kind of a cell with up to 100 nuclei and a bone pain. That means they're talking about the Paget's disease. Normally, the osteoclast cells, they have up to 5 nuclei, but in case of Paget's disease, they can have up to 100 nuclei. Okay, very important to note that. Okay, so any doubt on this disease?
No, thank you.
Okay, then comes the avascular necrosis of the bone, okay, which happens because of any kind of loss of blood supply to the medial circumflex femoral artery. Okay, you have two arteries, the medial circumflex and the lateral circumflex. Okay, the majority portion of this neck uh, of the femur, okay, it is provided by the medial circumflex femoral artery. And whenever the blood supply is lost, okay, from this femoral artery, the patient can have a avascular necrosis of the bone. And because it is a necrosis, it is always pathological. It is always followed by the inflammation. Patient can have a fever. They will have a bone pain. Very important. It is usually an acute bone pain that causes the patient to limp. Okay. Okay. And the most common site is the femoral head, which is the watershed zone. Okay. It is due to an insufficiency of the medial circumflex femoral artery. Okay, the causes include corticosteroid therapy. Okay, alcoholism can do that. Sickle cell disease can do that, because in the sickle cell disease you will be having a lots of formation of this uh, sorry, because of the hemolysis you will be having a this vaso-occlusive disorders, right? And because of the vessel occlusion, if the vessel occlusion occur in this middle circumflex femoral artery, patient can have the avascular necrosis also. Trauma can do that. SLE can do that. Okay, the Casen's disease can do that, because whenever you ascend from a high pressure state to a low pressure state, then the bubble formation can occur in your blood, right? And this bubble can even uh, occlude this femoral artery, and when this happens, this can lead to the avascular necrosis. Okay, lack of Purchase disease, which is a disorder of the childhood, okay, in which you're having an idiopathic avascular necrosis. It is also a cause of this disorder. Gaucher's disease, if you guys remember, you will be having a vaso-occlusion crisis also. In case of Gaucher's disease, the patient can present you with the abdominal pain, with the headache, with the extremity pain, and even the avascular necrosis of the bone, right? The slip capital femoris epiphysis is also a cause of this disorder, okay, in which you're having a this the attachment between the head of this femur, right? You will be having a slipping of this head of the femur. Okay, so these are all the causes of the avascular necrosis. Okay, it is always present with the chronic progressive growing pain, or they can tell you the hip pain, okay, that exacerbate by the weight bearing. Patient can also have the fever. Okay, systemic signs would be there, right? And on the physical examination, because it is involving the head of the femur, okay, and so patient can have a restricted joint movements. Okay, the patient will have a pain with the movement of the joint. But note that no swelling or erythema or the warmth is present. It is a very important thing. Although it is a necrosis, although the inflammation is there, but you cannot feel any swelling, any erythema, or any warmth. Okay, it's just a pain to the patient will be present. Okay, a pain with the joint movement. Okay, and a pain with the weight bearing exercises. Okay, these are the history of the patient with the avascular necrosis. Limping would be present, and generally patient will have a history of any of these causes. Okay, any doubt?
Is this a chronic condition or an acute condition?
It is an acute condition. It is usually present with the acute pain. Okay, but these patients generally have a history of pain for like 10 days or up to a month also sometimes, right?
Okay.
It depends upon the cause. Like in
Okay.
case of Gaucher's disease, the patient will have a very chronic history of this pain, right? In case of corticosteroids, a patient can have the episodic pain. Okay, so it depends upon the cause totally. In case of sickle cell disease also, you can have episodic symptoms, right?
Okay. Yeah. And you have written vasculitis, like which vasculitis can cause
Any
avascular
kind of
necrosis?
vasculitis can cause it. Small vessel vasculitis or the medium vessel vasculitis can cause them, mostly
Okay.
medial ones. Okay,
Okay. Okay. Yeah. Thank you.
yeah. Any doubt on this page so far?
No, thank you.
Okay, now then discuss the different lab values in different bone disorders. One is the osteoporosis, and you guys know that level of every hormone, every this electrolyte in your body will be normal. The calcium, phosphate, alkaline phosphate, PTH, everything is normal. But you just have a decrease in the bone mass. In case of osteopetrosis, you will be having sometimes a normal calcium or sometimes a low calcium level. Okay, because of too much utilization of the calcium for the bone formation, rest all other levels would be normal, right? Third one is the Paget's disease of the bone, in which you have only increase in the alkaline phosphate. Rest all levels are normal. In case of osteitis fibrosis cystica, that happens because of primary hyperparathyroidism, okay, or sometimes with the secondary hyperthyroidism, like in case of chronic kidney disease. Okay, in case of primary hyperparathyroidism, you'll be having a high level of calcium, low level of phosphate because of high level of PTH. Alkaline phosphate activity will be increased because of bone resorption, and high level of PTH will be also seen. It is also known as a brown tumors, right? And you generally have the subperiosteal thinning, right? These all the cystic spaces you can see on the X-ray of the patient, and these are generally the subperiosteal, right? For a secondary hyperparathyroidism, you will be having a low level of calcium, okay, and a high level of phosphate that leads to a high level of parathyroid hormone level and a high level of alkaline phosphate, generally seen in the chronic kidney disease, okay. Then the osteomalacia or the rickets, in which you are having a loss of vitamin D, and as a result, the low level of calcium, low level of phosphate will be seen, high level of alkaline phosphate and high level of parathyroid hormone level will be seen. Hypervitaminosis D, because you guys know that at the low levels, vitamin D can promote the bone growth, but at high levels, it can directly cause the bone resorption, right? So with the hypervitaminosis D, you'll be having a low level of parathyroid hormone level and a high level of phosphate as well as the high level of calcium would be seen, right? It can be caused by the oversupplementation or by any other granulomatous disease like the sarcoidosis, right? Very important. Okay, any doubt on these lab values?
No, thank you.
Okay, then let's discuss the primary bone tumors. We already discussed about the secondary bone tumor, if anyone remember. The metastasis.
Metastasis.
Yeah, these are the secondary bone tumors, right? The primary bone tumors are the ones which originate within the bone itself, right? Okay, so let's discuss them. Okay, just give me a second. Yeah. Okay, so you have two type of tumor because your bone is made up of this osteoid and as well as the chondroid material, right? You have the cartilage and you also have the bone. So the bone tumors can either be a cartilaginous tumor or they could be a tumor from the osteoids, okay, from the osteoblasts, right? So the first one is the osteochondroma, okay. Just give me a second again. Sorry about that. Instead of study this tumor like that, okay, we can change some part and we will study the tumors uh, you know with their location first, okay, from upper part of the body to the lower part of the body. We will study these tumors, right? So first of all, the tumor which is found on your face, the bone tumor which is found on your face, and this is the osteoma. Okay, the osteoma is generally a tumor that originates from the surface of the facial bones. Okay, and if you guys remember from the GI section, we have discussed about the familial adenomatous polyposis, right? And we have discussed about the Gardner syndrome. Okay, these patients with the osteoma, they present you with the facial bone pain, with the facial pain, along with the history of polyposis. And that means the patient is having a Gardner syndrome, remember?
Yes.
Okay, so osteoma for the face. Then comes the vertebra, okay, and you have the osteoblastoma, okay, which generally includes the vertebra, okay, and this kind of the patient present you always with the bone pain, and the bone pain is cannot be resolved by taking any NSAID or any other pain relieving therapy. Okay, the patient will have a continuous bone pain, okay, and it generally affects the vertebra of the patient. Okay, then comes the small bones of the hands and the feet, okay, and they generally have the chondroma, okay, which is a cartilaginous tumor, okay, and it originates from the medulla of the small bones of hands and the feet, and it is a benign tumor of the cartilage. Okay, then comes the pelvis. On the pelvis, you're having the chondrosarcoma. Okay, so on the small bones of hands and feet, it is the chondroma, which is a benign tumor. The malignant form of this tumor is found on the hips mainly, okay, the medulla of the pelvis, or sometimes the proximal femur. That means I can tell you about the hip joint. Okay, generally this hip joint is involved. In case of chondrosarcoma, patient will have a very hip pain, a severe kind of hip pain would be there, right? And this is a chondrosarcoma. Okay, then comes the long bones. Okay, for the long bones, we have the epiphysis. Let me just change this page. Sure. Yeah. So for the long bones on the epiphysis, you will be having a giant cell tumor. Okay, and a giant cell tumor is actually a tumor of the osteoclast cells, right? So what you can see are on the histology is the giant cells, are multinucleate giant cells, and these are nothing but just the osteoclasts, because you guys already know that the osteoclasts are multinucleated cells, right? It is a locally aggressive tumor, okay, a benign tumor it is, okay, but and it is a neoplastic mononuclear cells that express a rank ligand. That means they're talking about the osteoclast cells because these are the cells which express a rank ligand, okay. And you also can call it a osteoclastoma because it is a tumor of the osteoclast. You can also call it the osteoclastoma, okay. And what you can find on the X-ray of the patient would be the lytic lesions in the epiphysis, and it generally appears as this soap bubble kind of appearance, right? If you see this here, as you can see, these are all the lytic lesions, right? So this is the soap bubble appearance that you will see on the epiphysis of the bone, right? This is the osteoclastoma, which is a tumor of the osteoclast cells or the giant cells tumor. Any doubt on this tumor?
No, thank you.
Okay. Then comes the tumor from the metaphysis. Okay. And these tumors are the osteochondroma and the osteosarcoma. Okay. Now, just give me a second. Yeah. So the osteochondroma is the most common benign tumor. Okay, it originates from the metaphysis, of course. Okay, what you can have is the first is the osteoid part, and second is the chondroma part. Okay, so it has both the bone as well as the cartilage in the tumor. Okay, it generally present you with the lateral bony projection. Um, if you guys seen here, it is generally present you with the lateral bony projection. Okay, and yeah, and it is covered by the cartilaginous cap. So you have a bone which is laterally projecting, and on the sorry about that, and it is covered by the cartilaginous cap here. Okay, a bone with the cartilage, and this bone is continuous with the marrow space of this bone. This tumor is continuous with the marrow space of this bone. Very important. So this tumor will always present you with the lateral bony projection. Okay, and this bony projection is covered by the this cartilaginous cap. Okay, and this bony projection is continuous with the bone marrow space. This is the osteochondroma. Okay, any doubt?
No, thank you.
Okay, then comes the osteosarcoma, very important one. Okay, yeah. Osteosarcoma, it has a kind of two peaks. One is at a very early stage, and one is a very later age of the patient. Okay, so these patients, the first peak will occur in the males which are less than 20 years of age. Okay, and the late peak will occur in the patients with more than 50 years of the age, especially those with the Paget's disease of the bone. Okay, what happened? Like the name suggests, it is a osteosarcoma. It is a tumor of the osteoblast cells, okay, which are forming the bone. So it is like a bone forming tumor. Okay, it generally originates from the metaphysis of the long bones, often in the knee location. Okay, and what you can see on the patient is the pleomorphic osteoid producing cells. So when you do the biopsy of the patient, okay, generally patient will present to your OPD with a history of a bone pain. Okay, they have a severe warmth, severe bone pain. Okay, symptoms like the weight loss could be there, right? And they also have this tenderness over that area of the part where the tumor is present, and uh, and you can even feel the bone mass from your hands, right? And when you do the X-ray of the patient, you can see this Codman triangle. Okay, we will discuss that about soon, right? And the sunburn appearance of the X-ray also. So yeah, because of the newborn formation, this is the newborn formation happening, and this newborn formation, can elevate this level of the bone, which is normally here, but the level of the bone is elevated, and it will form a triangle like structure which is known as the Codman's triangle. Okay, because of the newborn formation in that area, okay, the bony part of that area will be elevated. Okay, and it will appear as a triangular part which is known as the Codman's triangle. You can also have the ossification of the nearby structures like the muscles, and because of the ossification of these muscles, the patient can also present you with this sunburned like appearance, sunburst like appearance, right? And it is because of the ossification of the nearby structures. Because these osteoblast cells, they will also ossify the bones. They will lay down this osteoid, and they will ossify it, right? So the ossification of nearby structures can also happen, and that can form the this sunburst appearance. So a Codman triangle because of the bone formation, and the sunburst appearance because of the ossification. That two things will be seen on the X-ray. And when you do the biopsy, you can see the osteoid producing cells. Okay, and that will be a diagnosis of the this osteosarcoma of the patient, right? If it is a primary type, then it has a very good treatment response. Okay, a very good prognosis would be there. But if it is a secondary to some other diseases like the Paget's disease, okay, then patient will have a very poor prognosis. And just like the Paget's disease, patient can have both the lytic lesions, which are the bone resorbing lesions, as well as the sclerotic lesions, which are the bone forming lesions. So both the lytic as well as the sclerotic lesions will be there in case of osteosarcoma. It is similar to that of Paget's disease. Okay. Very important. You can also get the osteosarcoma with the retinoblastoma, if you guys remember. Okay. And you can also get them with the Lee-Frommini syndrome. So whenever you encounter a patient with a family history of the cataract or the retinoblastomas, as well as the bone pain or the these bone cancers, that means the patient is having a retinoblastoma. If the patient has a history of SBLA cancer, which are sarcoma, breast cancer, leukemias, uh, or this adrenal gland tumors, okay, that means the patient is having a Lee-Frommini syndrome. Okay. And please remember, it is mostly present in the male patient with an age less than 20 years. Okay. Any doubt on the osteosarcoma?
No, thank you.
Okay. Do remember the symptoms of the patient: the bone pain, warmth, systemic symptoms like fever could be there, weight loss could be there, like, and you can feel this bone mass with your hands also on the palpation. The patient will have a localized tenderness, right? Swelling could be there. Then you can do the X-ray, in which you can get two things: sunburst appearance and the Codman's triangle. You can do the biopsy, in which you can see the osteoid, too much osteoid in the disorganized fashion. And yeah, the history of the patient is also very important. The age is important, and the patient's disease history is important. X-ray, you can also get the lytic lesion sometimes, right? And yeah, that would be everything about the osteosarcoma. Okay. Then you have the diaphysis, and on the diaphysis, you can have the osteoid osteoma as well as the Ewing sarcoma. So on the diaphysis of the bone, you can have the osteoid osteoma as well as the Ewing sarcoma. Let's discuss first about the osteoid osteoma. It originates from the cortex of the bone. You have two parts in the bone. One is the cortex, one is the medulla, and the osteoid osteoma originates from the cortex of the bone. Okay, the patient will present you with the bone pain, of course, like with any other cancer, but ironically, this bone pain can be relieved by the NSAIDs. Okay, this is the only tumor in which the bone pain can be relieved by the NSAIDs. But in all other tumors, you cannot get a relief by the NSAIDs only, right? You can have a bone mass which is often less than 2 centimeters. You have a radiolucent core, which is the osteoid. Okay, and then you have a bony mass, which is the osteoma. Okay, which is a real tumor, right? So that's why the name osteoid osteoma. As you can see, you'll be having this radiolucent core, and this is the osteoid material. Surrounding this, you'll be having a reaction. You'll be having a mass. Okay, and this is the osteoma, right? So osteoid and osteoma, two parts. Very important. So yeah, that would be everything about the osteoid osteoma. Any doubt?
No, thank you.
And then you have the Ewing sarcoma. Very important. It is generally seen in the boys which are less than 15 years old. Okay, it originates from the diaphysis, especially the femur is a location. Okay, just like with any other bone tumor, you will be having a bone pain and a warmth over that area. Tenderness could be there, systemic signs could be there, weight loss would be there, right? And when you do the X-ray of the patient, you can even see the bone mass. Okay, the important thing to note that it is a tumor of the mesenchymal origin. Okay, initially it was thought that it could be a tumor from the neuroectodermal origin, but now it is concluded that the tumor is of the mesenchymal origin. I don't know what the FA2021 had this mentioned, but the FA2020 mentioned about the neuroectodermal origin. But on the UWorld, it was mentioned that earlier it was a neuroectodermal origin, but now it is concluded that that these tumors are of the mesenchymal origin. Okay, so if the 21 mentioned this part about the mesenchymal origin, then okay. If it is still mentioned this neuroectodermal origin, you can change that to the mesenchymal origin. Okay, what you can see on the histology of the patient, these are these small blue round cells, as you can see. These are the small blue round cells you can see on the X-ray, and these are all the mesenchymal cells that can resemble the lymphocytes. Okay, so you need to differentiate this condition with the inflammation of bone, known as.
Could you please repeat?
What is the inflammation of the bone known as?
Osteitis.
Yeah. Sorry about that. Just give me a second again. Yeah, osteomyelitis, not the osteitis. I was forgetting the name. Sorry about that. Yeah, this condition can even mimic the osteomyelitis, in which you are having also the this lymphocytes and the neutrophils sometimes, right? So you need to be able to differentiate, okay, this Ewing sarcoma with the osteomyelitis, right? Because in case of chronic osteomyelitis, you will be having a similar histology. In case of lymphoma also, because a lymphoma is a tumor of these lymphocytes, right? So you can have the numerous lymphocytes in this case also. Okay, so you need to able to differentiate this tumor with the lymphoma as well as the chronic osteomyelitis, because in both these disorders you can also see the small blue round cells like the lymphocytes, right? And the one thing you could do is to check for the with this fusion protein EWS-FL11, okay, which happens because of translocation between the chromosome number 11 and the 22. So a translocation of 11 and 22, along with this histology, confirms the diagnosis of the Ewing sarcoma. So the age of the patient is important, less than 15 years of age. This translocation is important, and then the histology is important, right? And on the X-ray, you can even see the onion skinning. Okay, it is a lytic lesions which is surrounded by the concentric layers of the radioactive bone. Okay, if the stamp one mentioned you this, that a lytic lesion is there which is surrounded by the concentric layers, or I can say the onion skinning, right, of the reactive bone or the periosteal reaction, as you can see. So it would be a lytic lesion which is surrounded by the onion skinning or the concentric layers of the radioactive bone. This is what you see on the X-ray of the patient, right? And it is very aggressive, and the patient will also have an early metastasis in that case, right? So any doubt on the Ewing sarcoma?
No, thank you.
So I think we have covered every tumor. Okay, so you have the osteoma phase. So study these tumors in the sequence. Okay, from head to toe. First on the head, on the face, you'll be having the osteoma. Then goes to the vertebra, you will be having the osteoblastoma. Then the small hands, in which you're having a chondroma. Then the hip, in which you're having a chondrosarcoma. Okay, then comes the long bones. For the epiphysis, you'll be having a giant cell tumor. For the metaphysis, you will be having a this osteochondroma and the osteosarcoma. On the diaphysis, osteoma, and the this Ewing sarcoma. Right? That's how you can study these tumors, and you can remember every feature of these tumors, right? So any doubt on the bone tumors?
No, thank you.
Okay, then you have another case which can mimic, the case of these tumors also, because in whenever the patient with a tumor present, they will always complains you with the bone pain and the warmth, right, and the tenderness over the area. These are the presenting complaints of the patient uh, with these bone tumors, right? One another condition that can mimic these tumors is this osteoitis ossificans. Oh, sorry, the myositis ossificans. Okay, the myositis ossificans. And if you guys remember the general pathology lectures, we have discussed about this metaplasia, right? And in the metaplasia, we have mentioned one example, which is the myositis ossificans. And as the name suggests, it is the ossification of the muscle. Okay, and that happens because of the inflammation of the muscle. Okay, generally it happens because of a sudden trauma to the muscle. Okay, like you know uh, generally a kick from an animal like a horse on the thigh. The most common location is a thigh. So patients generally have a history of a trauma like a kick from any animal like a horse, okay, on the thigh. And after that trauma, the patient will started having this bone formation, the ossification of the muscle. So the patient will present with the bone pain, with the tenderness, with the warmth over that area, right? On the X-ray, what you can see is the ossification, just like this sunburst appearance that you have seen in the osteosarcoma. The similar appearance can be seen in the this myositis ossificans also. The ossification of the bone you will see. Okay, but it is not a sunburst type. It is a very localized type of bone formation. Okay, and it generally presents you with a very mobile mass, a painful mobile mass. Okay, and the ossification happen. It has a very regular borders. Okay, it is a very well demarcated area, not like the sunburst appearance. Okay, a very well demarcated mobile mass will be there. Okay, in the thigh or in the location where the trauma happened, right? And on the histology, you can see the metaplastic bone formation. Okay, a benign metaplastic bone surrounded with the fibroblast proliferation that you will see on the this microscopic examination of the patient. A benign metaplastic bone formation which is surrounded by the fibroblast proliferation, right? So, any doubt on the myositis ossificans?
No, thank you.
So that would be everything on these 2 pages on this table about the bone tumors. And do remember the secondary tumors or the metastatic tumors are more common than the primary bone tumors, right? Very important. Okay. Now come the osteoarthritis, okay, which happens because of a mechanical wear and tear of the joint. Okay, in the joint space also, you're having some formation cells, okay, and the resorption cells also, right? And when the formation is kind of less than the resorption, okay, then you can have the osteoarthritis. Okay, you'll be having a destruction of the articular cartilage, okay, and it happens because the chondrocytes which are repairing the cartilage, they will become defective, and as a result the resorption of the cartilage of the articular cartilage between the bone is increased, and the formation or the repair of that cartilage is decreased. As a result, with the age, as you use this joint, okay, the resorption will become increased, will be this joint will be resorbing, and as a result the cartilage will be gone, and now the bony surface will be exposed. And when the bony surface is exposed, you can have the formation of the bone spurs. Okay, so what is the pathology? It is because of a mechanical wear and tear of the joints. Okay, because of the mechanical wear and tear, you will be having a destruction of the articular cartilage. Okay, the osteocytes will try to repair it, but they fail to do so. Okay, and because of this thing, because of a defective repair of this joint space by the chondrocytes, you will be having a destruction of articular cartilage. As a result, finally the cartilage will be gone and the bone uh, will be exposed, right? The two bones in the joint will be kind of in contact with each other, right? And as a result, they will become very inflamed, and the bone spur formation can occur, and that all leads to the osteoarthritis. Okay, it is due to the chondrocyte dysfunction. It is a type 2 collagen defect because it's a defect in the cartilage, not in the bone itself. Okay, very important. It is a defect of the cartilage, not the bone. Factors, first of all, includes the age of the patient. Highest risk factor is the age. Then the female is very important. Obesity and any kind of joint trauma is also important. Smoking is not a risk factor for the osteoarthritis. Very important. Okay. And what would the patient present to? They will present with the pain, okay, in the weight bearing joints after the use. Okay, as long as the patient uses a joint, the pain will become very much progressive and very much severe. Okay, and so that the patient will become the pain will become very much severe at the end of the day. These are the complaints of the patient. Okay, the pain will improve with the rest also. Okay, patient can also have the joint stiffening, okay, for up to few minutes after the wake up. When the patient wake up from the rest after sleep, then they can have this joint stiffening for up to several minutes, like 5 to 10 minutes. Okay, but do not confuse this with the case of rheumatoid arthritis. In case of arthritis, you will be having that joint stiffness for more than an hour. Okay, so if a prolonged stiffness will be there for like more than an hour, then it is the rheumatoid arthritis. But in case of osteoarthritis, you will be having a stiffness for few minutes only, right? And it is the asymmetric joint involvement, which means these are generally a unilateral condition. Okay, but in case of the rheumatoid arthritis, it is a symmetric or a bilateral condition. Okay, very important. And you do not have any kind of systemic symptoms in case of arthritis, osteoarthritis. Okay, so the patient will generally have only the history of the bone pain that will become severe at the end of the day with the successive use of the joint. Okay, you can also hear some sounds on the joint space. Okay, with the auscultation. Okay, and you can have the crepitus on the joint flexion and the extension. Okay, you can have the crepitus on the joint flexion and the extension. Okay, so what are the joint findings? You will see now these are the symptoms. Okay, and after that you will have to run some test. You will have to diagnose the patient. So what are the joint findings you will see? One is the osteophyte or the bone spur formation. Now, because of the loss of this cartilage, okay, the bone will become very much closer to each other. The two bones will become very much closer to each other, as you can see like that, right? The bones are exposed in the joint space, right? And when the bones rub against the bone on the joint use, when the bone rub against this bone on the joint use, the patient can have a bone formation there. Okay, and these are the osteophytes. Okay, because the cartilage is not there to protect these bones. Okay, the bone formation will become very too much, and these will form the osteophytes. Okay, because of loss of cartilage, okay, the joint space will become very narrowed. Okay, subchondral sclerosis would be there. Okay, very important. You can have the cyst formation also. Okay, synovial fluid examination, when you do it, is a non-inflammatory type, which means the WBC coin discount will be less than 2000. Okay, while in other inflammatory conditions, like in case of rheumatoid arthritis, you can have the WBC count for more than 12,000 also, right? Very important. And please note the joint involvements. These are the distal interphalangeal joints, okay, and the uh, proximal interphalangeal joint. Okay, MCPs are not involved in case of osteoarthritis. Very important. If you encounter a patient with the metacarpophalangeal joint involvement, then they are not talking about the osteoarthritis. They are talking about the rheumatoid arthritis. Okay, while in case of osteoarthritis, we will be having a DIP involvement, which is never seen in case of this rheumatoid arthritis. DIP only in case of the osteoarthritis, while the PIP is in the case of both the osteoarthritis as well as the rheumatoid arthritis. Okay, MCP only for the rheumatoid, not for the osteoarthritis. Okay, so these are the joint findings. On the synovial fluid examination, when you do when you do the biopsy or when you do the examination in the microscope, okay, what you will see is the free floating cartilage tissue. Because the cartilage is being resorbed, is being damaged. Okay, all this cartilage tissue will present in the synovial fluid that you can see in the microscopy. So it is the free floating cartilaginous tissue you will see on the microscopy, and the fragments of the chondrocytes can also be seen in the synovial fluid. Okay, so it is the free floating cartilaginous tissue fragments in the synovial fluid, and when you do the zoom, you will see the chondrocytes in them. Okay, so free floating chondrocytes in the synovial fluid you will see on the examination, right? And the age of the patient, these are mostly patients more than 50 or 60 years of the age. Okay, very important. And whenever you encounter a young patient for like 40s or 40 to 50 years of age, that means it is the rheumatoid arthritis. While a patient more than 50 years of age, it is mostly the osteoarthritis case. So age of the patient is also a very important risk factor, right? So what is the treatment? Treatment includes activity modification. NSAIDs could be useful. Okay, and the intra-articular glucocorticoids are also used. Very important. So Any doubt?
No, thank you.
The osteoarthritis, no? Okay. Okay, so we can take a short break of 10 minutes and then start with the rheumatoid arthritis, okay?
Okay.
Okay. Okay, so we have discussed this osteoarthritis, and now let's discuss the rheumatoid arthritis, which is an autoimmune condition, okay, in which your lymphocytes are formed against the rheumatoid antigen, okay, which is citrulline and the type 2 collagen, okay, citrulline and the type 2 collagen are the rheumatic antigen, and against which these T lymphocytes will become activated. Okay, and please note that the rheumatoid arthritis involves both the humoral as well as the cell-mediated immunity. Okay, and especially Th1 cells and Th17 type of cells are activated. Okay, they release the TNF alpha and the interleukin 1, and that's why one of the treatment of the rheumatoid arthritis is to inhibit the TNF alpha and the interleukin 1. Right, very important. Now, so what happens is when these T lymphocytes become activated against the citrulline and the type 2 collagen, okay, they releases these inflammatory cytokines, the interleukin 1, TNF alpha, and other interleukin cytokines, and that causes the synovial hyperplasia. Okay, the synovial membrane, which is made up of this epithelium, hyperplasia of the synovial membrane occurs, right? And because of this synovial hyperplasia, you will be having a rheumatoid pannus formation. Okay, you'll be having a rheumatoid pannus formation that includes the proliferative granulation tissue. Okay, along with the synovial hyperplasia, okay, because of this local tissue hypoxia, as the cells are proliferating, they needs more blood supply, right? So now the vascular endothelial growth factors are also released by the macrophages that causes the synovial angiogenesis. So a new vascularization will also be happening. So the first step is the activation of the cells. Second is the synovial hyperplasia. Third is the angiogenesis. Okay, and when the hyperplasia and angiogenesis occurs, that forms a proliferative granulation tissue, which is also known as the pannus. Okay, the rheumatoid pannus. It is like an invasive mass, okay, which is present in your synovial space, and that causes the destruction of both the cartilage as well as the bone. See, in case of osteoarthritis, you're having just a destruction of the cartilage. Okay, the bone is normal, or even you're having the over growth of the bone in the joint space, right? You're having this bone spur formation. But in case of rheumatoid arthritis, you're having a destruction of both the cartilage as well as the bone itself, as you can see in the diagram also. You're having a bony destruction as well as the cartilaginous destruction, right? And it is all because of the rheumatoid pannus formation, which is kind of an invasive mass, right? It is an example of type 3 as well as a type 4 hypersensitivity reaction, mainly the type 3 one. Okay, and generally seen in the females most commonly, okay, or the individuals which actually actually DR4 positive. Okay, the patient will have antibodies against the rheumatoid factor, okay, which is the IgG antibodies. That means these are the body, and these are the rheumatoid factors. Okay, very important. You also have the anti-cyclic citrulated peptide antibody, and these are the specific tests. If the step one asks you what could be the sensitive test for the rheumatoid arthritis, it is the rheumatoid factor antibody, right? If they ask you about the specific test, then please note the anti-cyclic citrulated peptide antibodies are the specific test you can do for the rheumatoid arthritis. Okay, very important. Now, what are the symptoms the patient present with? The patient generally present with the joint pain, okay, and it is a symmetric type of joint pain, unlike the osteoarthritis, which is the unilateral. The rheumatoid arthritis kind of bilateral joint pain. Okay, both the side of joints will be involved. The patient will have a very prolonged stiffness in the morning, more than an hour. In case of osteoarthritis, the stiffness is for like 10 to 20 minutes. In case of this rheumatoid arthritis, it is more than an hour. Okay. Other thing, um, yeah. And this pain is generally improves along with the use. Unlike in case of osteoarthritis, in which you have a pain with the use of the joint. In case of rheumatoid arthritis, you're having a pain at the rest. With the joint use, the pain is resolved. Okay, very important to note that. Okay, and so that's why the patient will have a morning stiffness that will be resolved along with the use of the uh, this joint, right? The patient, because it is an autoimmune condition, it is an inflammatory condition, patient will also have a will also have the systemic signs and symptoms that includes a fever, fatigue, weight loss, right? These are also there. Extra articular manifestations are also common that includes a rheumatoid nodule, okay, which is kind of very hard nodule on your elbow. Okay, and it is an example of the fibrinoid necrosis. If you guys remember the general pathology lecture, we have discussed three examples of the fibrinoid necrosis. One is the hypertension, a malignant type of hypertension. Second is a vasculitis, and third is the rheumatoid nodule. Okay, so these are the example of fibrinoid necrosis. Is that it is a type 3 hypersensitivity reaction because of these immune complexes. They will deposit on the elbow and they will present you as the rheumatoid nodules. Okay, patient can also have this Kaplan syndrome, which is the rheumatoid arthritis with the pneumoconiosis. You will also have the interstitial lung diseases, which means the fibrosis. So the pulmonary hypertension could also be there in this case. Patient can also have the involvement of the pleuras. Inflammation of the pleuras can happen that can lead to the pleuritis. Okay, so a pain with the inspiration, a chest pain with the inspiration is a typical pleuritic chest pain. Pericarditis can also occur if you guys remember from the CVS lectures. The pericarditis can also occur, right? Anemia of chronic disease, because it is a chronic disease, patient can also have the anemia of chronic disease. Anemia would be there, right? Neutropenia could also be there. Splenomegaly will also be there. Amyloidosis can also happen because of this chronic inflammation, AA type. Sjogren's syndrome is also associated with the rheumatoid arthritis, and that's why you need to give the patient pilocarpine as a treatment of the rheumatoid arthritis, because a Sjogren's syndrome can cause the dryness of the body secretions. Carpal tunnel syndrome can also happen because of this amyloidosis and because of the inflammation of the joint spaces. Okay, small joints can also be happen like the MCPs, right? And that can lead to the carpal tunnel syndrome. Okay, patient on the joint findings, the patient can also have the soft tissue swelling. Joint space narrowing would be there, just like the osteoarthritis, but both cartilage as well as the bone resorption will be there in case of rheumatoid arthritis. Okay, cervical subluxation is also very common, and that can lead to the paralysis of the patient. Okay, the patient will present you with the neck pain and the neck stiffness. Okay, and whenever you try to manipulate the neck, like during the nasogastric tube placement, okay, in that case you need to do the extension of the neck. Okay, and in a patient uh, with the cervical subluxation, if you do the hyperextension, then it can lead to the compression of all the this spinal cord segment there, and as a result it can cause the paralysis. So it will be a patient with a history of joint pain, right? And when you try to do the manipulation of the neck, like during the placements of this nasogastric tube, okay, and the patient suddenly have this paralysis thing, right? And that's how you know the patient is having a compression of the spine there, of the spinal cord there, and because of the cervical subluxation. It is also very much common with the rheumatoid arthritis. Okay, patient can have a ulnar finger deviation, in which the fingers are kind of deviated towards the ulnar side, which means towards the medially. Patient can also have a Sean neck deformity of the fingers, as you can see, right? These are the Sean neck deformity. Okay, very important. And the patient can have an involvement of the metacarpopharyngeal and the proximal intrapharyngeal joint. Very much important. DIP is not involved. Okay, very important to note that. And first metacarpopharyngeal joint is for the osteoarthritis. It is also not involved in the rheumatoid arthritis. So you can say the rheumatoid arthritis is more of a proximal condition. Okay, while the osteoarthritis is more of a distal condition involving a DIP. Right, very important. Treatment includes anti-inflammatory agents like the NSAIDs. These are the first line agents. Okay. Glucocorticoids can also be given. Okay, and these are only for the acute management of the disease when the pain is there. Okay, the chronic management is done by the disease modifying drugs or the DMARDs, right? And these include some methotrexate, sulfasalazine, sulfadiazine, TNF alpha inhibitors, and other therapies. We will discuss that later in the pharmacology section. Okay, so these are a treatment for the rheumatoid arthritis. Any doubt?
No, thank you.
Okay, so that's everything about the rheumatoid arthritis and the osteoarthritis. You need to be able to differentiate between the two disorders by looking at the symptoms, by looking at the joint findings, by looking, uh, on the kind of joint involvement of the patient, right? And yeah, the age is also very important. This important factor, right? The age is mostly 40 to 50 years in case of rheumatoid arthritis, and more than 50 years in case of osteoarthritis. Okay. Any doubt?
No, thank you.
Okay, so that's all about it. So that is the pathogenesis of the rheumatoid arthritis. You will be having an activation of the lymphocytes, okay, which are active against the rheumatoid and this antigen, which is the citrullin and the type 2 collagen, which means the cartilage, right? The patient can have a synovial hyperplasia, okay, and because of the hyperplasia, this hypoxia happened, so that this angiogenesis can also happen, and this angiogenesis along with the hyperplasia forms a rheumatoid pannus, which is a kind of this invasive mass, okay, in the joint space, and that can destroy the articular cartilage as well as the bone. Very important. You will also have a vertebral subluxation in case of rheumatoid arthritis, right? And that can involve cervical spine. Okay, atlantoaxial joint is involved, neck pain and this stiffness would be there, right? And the neurological findings like the sensory loss or the muscle weakness would be there. And whenever you try to manipulate your neck, right, with the hyperextension, like in case of any intubation, right, patient can have a flaccid paralysis with loss of all the reflexes below the level of the compression. Okay, so it would be a quadriplegia you will get in this case, the paralysis of all four limbs, right? Then comes the gout, which is an acute inflammatory monoarthritis. It only involves one joint, and that's why the monoarthritis, it is an acute condition, and acute inflammation of the joint happens, right? So it will always present with the acute severe onset of pain in the joint. Could be a toe, could be a knee joint, right? But it's always the acute condition. It is associated with the hyperuricemia or the high uric acid level. Okay, and whenever the high uric acid levels are there, they will form the crystals, which are the monosodium urate crystals. Okay, and these crystals start depositing in your joint space in the synovial fluid. Okay, and whenever these crystals start depositing, okay, they will cause the chemotaxis of the neutrophils. Okay, the neutrophils will come there in the joint space, and uh, uh, they will form a inflammation, they will produce an inflammation against these crystals, and because of that inflammation you will be having a this arthritis. Okay, risk factors include some male sex. Okay, male sex is very important. Hypertension is important. Obesity, diabetes, dyslipidemias, alcohol use, because in alcohol use it will be having a utilization of the proteins, and that can cause a hyperuricemia also. Okay, strongest risk factor is the hyperuricemia. Okay, so the most important risk factors is the hyperuricemia, and this hyperuricemia can be happen either by the under excretion or by the overproduction. For the under excretion, you have the kidney dysfunction whenever a patient with a chronic kidney disease is present. Okay, in that case they will be having a high level of this uric acids. Okay, so history of this chronic kidney disease is important. Other drugs which can decrease the clearance of this uric acid, that includes the diuretic agents, okay, like the thiazide diuretics. Okay, NSAIDs at a low dose will also compete for the excretion by the kidney, and as a result, the excretion of the uric acid is decreased. So a low dose of the NSAIDs, okay, will also cause this hyperuricemia, okay. So yeah, and mainly it is the idiopathic cause only. Then comes the overproduction, and that can happen with the Leach-Nyhan syndrome. We already know that, we studied that already. With the PRPP excess, and does anyone know why the PRPP excess can cause the hyperuricemia?
More formation of purine nucleotides.
Yeah, because of increase in the formation of the purines, and as a result, the degradation of these purines will also be increased, and as a result, you will get the high level of uric acids. Okay, any kind of tumor can cause this hyperuric acid levels, because in this case, you will be having a high cell turnover. Okay, and every cell has the DNA, every cell has a nucleotide. Okay, and whenever cell destruction happen, that can lead to the tumor lysis syndrome, and you can get the gout in that. Von Gericke's disease, if you guys remember, they can also cause the hyperuricemia. And does anyone remember the von Gericke disease? What happened in it?
Glucose 6 phosphatase
Where is the
deficient.
pathology? Yeah. And as a result, all of the glucose 6 phosphate is being trapped inside the cell. Okay, and as a result, all of the ATP will be destructing AMP, and then the adenosine, and finally in the uric acid, right? Because the phosphate is not available. So the uric acid level will rise. Okay, any leukemia, any myeloproliferative disorder, any kind of tumor can cause the hyperuricemia, right? And they can cause the gout then. Okay. So any doubts so far about the risk factors and the cause of the gout?
No, thank you.
Okay, so now, what are the joint findings? Okay, so first of all, for the diagnosis of this condition, you need to aspirate the joint fluid. Okay, and when you aspirate the joint fluid, you will look under the microscope, and what you will find is the needle-shaped crystals. Very important, and these are negatively bifringent and under the polarized light, which means, okay, in the parallel light they will be yellow, and in the perpendicular light they will be blue, right? Serum uric acid, they may not be elevated in the acute onset of the condition. Whenever acute pain is there, okay, and you measure the serum uric acid level, it will be absolutely normal. Only in the chronic diseases, okay, in between the episodes, you can have a high level of uric acid. At the time of episode, the uric acid level will be normal, so it is not a diagnosing thing. Okay, other thing you can get is a neutrophils. Okay, high level of neutrophils would be there. Okay, and the important thing to know that a WBC count in case of this acute gout will be less than 50,000. Very important. Okay, so look for the labs. If the labs of the patient showing a WBC count more than 50,000, that means it is not the gout, it is a septic arthritis. Okay, only in case of septic arthritis you can have a WBC count more than 50,000. In case of gout, the WBC count will be less than 50,000, like around 20 or 30,000 sometimes, but not the 50,000. Okay. So look for WBC count also. It will help you. And note that the uric acid crystals are found in the kidneys. Okay. And the monosodium urate crystals found in the joints. And these are the needle-shaped crystals, as you can see. Okay. These are the needle-shaped crystals. Okay, and because of deposition of these crystals, you will have the neutrophil chemotaxis, and that can cause the inflammation. Symptoms include the asymmetric joint distribution. It will be asymmetric acute onset of joint pain. A severe joint pain will be there. Okay, the joint will become very swollen, very red, and very painful. Okay, classic manifestation is a painful MTP joint. Okay, and it is not very much important to note. Okay, acute attack generally happens after a aggravating factor. That means any factor which can further increase the uric acid levels, which can precipitate the uric acid crystals in the joints, they can cause an acute attack, and that generally happens after the alcohol consumption or a very protein-rich diet. Whenever the patient consumes a protein-rich diet, that can lead to a surge in the uric acid level, and that can cause a gout. Whenever the patient drinks alcohol, they can cause the gout, right? So generally, patient will have a history of a party a night before the attack. Okay, any kind of a party a night before the attack, they generally present with this kind of a history. Okay, trauma could also be there. Dehydration, diuresis can also be there, because with the with the diuresis and with the dehydration, patient can have a high level of uric acids, because ultimately it's the concentration of uric acid that is the important thing, right? And whenever you have a dehydration, whenever you have a diuresis, you can have a high concentration of the uric acid that can precipitate and form the these crystals, right? So yeah, that's all the symptoms and the aggravating factors of the gout. Okay, any doubt in this part?
No, thank you.
Okay, so just remember what are the classical presentation of a patient with the gout. It would be a joint pain, a severe kind of joint pain. Patient present in the emergency department generally. Okay, joint will become very red, very swollen, very tender. And when you aspirate the fluid, because that is a definitive thing you can do to the patient, you will find the crystals, right? And you will find the WBCs. Okay, and please note the WBC count is less than 50,000. If it is more than 50,000, that means it is a septic arthritis, because both in case of gout and as well as in the septic arthritis, you can have a acute onset of joint pain. So you need to be able to differentiate between the gout and the septic arthritis case, right? And generally, patient have a chronic history. Okay, they will have a history of the episodic pain. They will tell you that they have a similar kind of pain in the past before, right? And yeah, these aggravating factors would be there, like alcohol consumption or any kind of protein-rich diet a day before the onset of the symptoms would be there, right? Treatment includes the NSAIDs. These are the first-line therapy. If the NSAIDs are not available, you can give the patient colchicine. Okay, if the colchicine is not available, then you can give the patient glucocorticoids, and these are for the acute therapy. Okay, when the pain is there, you need to control the pain. You need to control the inflammation first, and that's why you can give the patient NSAIDs. The chronic condition for the prophylaxis, you need to prevent the uric acid surge. Okay, you need to prevent the high level of uric acid, and that could be done by the xanthine oxidase inhibitors like the allopurinol and the febuxostat. So these are for the chronic therapy. For the acute therapy, whenever the patient come into a department with the pain, you will always give the patient NSAIDs, colchicine, and then the glucocorticoids, right? Any doubt?
No, thank you.
So that would be everything about the gout. And similar to the gout, you can have another condition, which is the calcium pyrophosphate deposition. Okay, similar to the gout, in which you're having a monosodium urate crystals. In case of this disorder, the pseudo gout, you will be having a deposition of calcium pyrophosphate crystals. And just like these crystals, the monosodium urate crystals, they can also cause the neutrophil chemotaxis. The neutrophils will come into the joint space and they will cause the inflammation of the joint, right? And these are generally seen in the patients with the age more than 50 years. Okay, condition is usually idiopathic. Okay, they do not have any specific cause. Okay, but sometimes they could be associated with the hemochromatosis, hyperparathyroidism, and the joint trauma. Very important. In these conditions, you can have the calcium pyrophosphate deposits. Okay, unlike the monosodium urate crystals, which are negatively bifringent, these crystals are positively bifringent, which means they will be blue in parallel and they will be yellow in perpendicular. Okay, and again the patient will have a severe onset of the joint pain. It is most often a knee pain. Okay, patient will have a tenderness, will have a swelling, will have a warmth, will have a redness over the area. Okay, and on the labs you will have a high level of WBCs, but less than 50,000, of course. Neutrophils will be there. Okay, because ultimately these are the neutrophils causing all this inflammation, right? And you can also have the chondrocalcinosis, which means the cartilaginous calcification on the X-ray of the patient. It is highly specific for the calcium pyrophosphate deposition. Okay, and patient can also have a high level of calcium in the blood, and only because of this high level of calcium, patient can have a metastatic calcification, right? And sometimes a metastatic calcification can also lead to the calcium pyrophosphate disease. Very important, right? And crystals are rhomboid shaped, while in case of monosodium urate, these were needle shaped. In case of the calcium pyrophosphate, as you can see, these are the rhomboid shaped crystals. Okay, and they will be blue in parallel light and yellow in perpendicular light. Treatment includes just like the gout, NSAIDs, colchicine, and the glucocorticoids, but the prophylaxis involves only the colchicine use, not the uric acid controlling agents, right? Very important. So, any doubts so far?
No, thank you.
Okay, so the inflammatory response in case of any gout attack or in case of this calcium pyrophosphate disease, it is all because of the neutrophils. So if you are somehow able to control the neutrophils, you can prevent the acute attacks, and that could be done with the help of NSAIDs or with the help of colchicine, because you guys know that the microtubules are responsible for the cell movement. If the microtubules are not there, then the cell movement cannot occur. Okay, these neutrophils cannot reach to the inflammatory cell location, right? And as a result, the inflammation won't occur. And that's why the colchicine is a very useful therapy in case of gout. Then comes the systemic juvenile idiopathic arthritis, which is seen in the teenage patients. Okay, the age of the patient is usually less than 16 years of age. And as the name suggests, it is systemic. Okay, so the patient generally present with the systemic signs and symptoms of the inflammation that includes a fever, this fatigue and the weakness would be there, right? So the patient will present with a daily spiking fevers. Okay, a pink macular rash would be there, and arthritis, and generally multiple joints are involved. More than two joints are commonly involved. Okay, patient can also have the anterior uveitis because it is a systemic inflammation. It can also involve the uvea. Patient can have an anterior uveitis. Okay, and of course, because of the inflammation, patient will have a high level of WBCs, high level of thrombocytes for the clotting, of course, and patient can also have the anemia because of the inflammation. Patient can have the high ESR, high CRP levels. Treatment includes anti-inflammatory agents like the NSAIDs, steroids, TNF-alpha inhibitors, and the methotrexate. Okay, so nothing much special about this systemic juvenile idiopathic arthritis. It's just arthritis with the systemic involvement. Okay, only seen in the teenage patients less than 16 years of age. Any doubt?
No, thank you.
Okay, then comes the Sjogren syndrome. Okay, and for a Sjogren syndrome, you need to know that it is also an autoimmune condition in which you have a destruction of the exocrine glands, especially the salivary glands and the lacrimal glands. Okay, lacrimal glands which produces a tear, and salivary glands which produces the saliva. You're having a destruction of these glands. Okay, and especially the ducts of these glands. Okay, so because of the ductal destruction of these glands, you will be having a decreased secretion from these glands, and as a result, the dryness would be there. Okay, now these conditions are predominantly affects a female of the reproductive age, which is between the 40 years and the 60 years. Okay, you will be having a lymphocytic infiltration in this disorder. Of course, it is a chronic autoimmune disorder. Okay, and just like any other chronic autoimmune disorder, you can have a lymphocytic infiltration also, but a very kind of specifically you are having a germinal center formation. So on whenever you do the biopsy of the patient, okay, of these glands, of the ducts of these glands, what you will find are the follicles and the germinal centers on the biopsy. Okay, just like the remember the hypothyroidism, we have discussed that one cause of the hypothyroidism can also have the germinal center formation. Remember the name?
Hashimoto.
Hashimoto thyroiditis, yes. In case of this Hashimoto thyroiditis, you can also have a germinal center formation and the follicles, right? Similar things, similar kind of histology could also be seen in the Sjogren syndrome. And just like the Hashimoto thyroiditis, the Sjogren syndrome has a very much malignant potential of becoming the mucosal associated lymphoid tissue, or the MALT, right? It is a marginal zone lymphoma. Okay, if you guys remember from the lectures, hematology, right?
Yeah.
Hashimoto thyroiditis and the Sjogren syndrome, they can become the marginal zone lymphoma, right? So do remember that. So what are the findings? Findings will be the inflammatory joint pain. You guys know that this Sjogren syndrome is associated with the rheumatoid arthritis also. So the patient can also have the joint pain. Because of this loss of lacrimation, you will be having a dry eyes. And because of the dry eyes, patient can also have the corneal damage. Okay, inflammation in the eyes would be there, and it is known as the conjunctivitis, which is the inflammation of the conjunctiva. It has a special name known as the keratoconjunctivitis sicca, and it is nothing but just the conjunctivitis in the patient. Patient can also have the xerostomia, which is because of a decreased saliva production. You will be having a mucosal atrophy, dryness of the mouth will be there. Patient can also have the furrowing and fissuring of the tongue, as you can see. Okay, and because of loss of the saliva, patient cannot chew the food properly. Okay, the patient will have a history of the dysphagia. Okay, they generally told you that they cannot chew the cracker. Okay, this is a most common presenting complaint. Dry mouth. Okay, patient can also have a presence of the anti-nuclear antibodies or the ANA. Okay, rheumatoid factor is also positive, and that's why the FA said that the rheumatoid factor is a sensitive marker. Okay, for the rheumatoid arthritis, but not the specific one, because it is also elevated in the Sjogren syndrome, right? Along with the rheumatoid arthritis. Okay, patient can also have the this ribonucleoprotein antibodies, which is the RNA antibodies. See, the anti-DNA antibodies are seen in the SLE, and the anti-RNA antibodies are seen in the Sjogren syndrome. And these anti-RNA antibodies are anti-SSA and the SSB antibodies, which is anti-RO and anti-LA. So do remember these names. These are the anti-RNA antibodies, SSA and SSB. Okay. Parotid gland involvement is very much common also. And because you're having a dryness of the mouth, and you guys know that the saliva flow is a very important protective factors against the bacterial infection, right? And because you're having a loss of this saliva flow and this dryness of the mouth, you can also have the infection with the bacteria of the salivary glands, right? So the patient can also have the inflammation, okay, which is known as a salidinitis, if you guys remember. Okay, inflammation of salivary glands. Because of this loss of saliva, because saliva also contain the antibodies, IgA antibodies, right? You will be having a loss of IgA antibodies, and that can lead to the infections in the mouth. Infections of the teeth would be there, right? Infections of the gum would be there in the patients. Okay, very important. Dental caries would be there, right? So complications include dental caries because of the dry mouth, because of loss of the antibodies. Okay, mucosal associated lymphoid tissue, which is a chronic complication of the disorder, right? Lymphoma can happen. Bilateral parotid gland enlargement would be there. Infection of the parotid gland could be there, right? And salivary glands atrophy could also be there. Okay, and how you can diagnose this condition? You need to take the biopsy of the labile gland. Very important. You also have the salivary glands in the lips, and because salivary glands are involved, you can take the biopsy from the lips of the patient and you check for the labile salivary glands. Okay, and that will be having a formation of the terminal centers and the destruction of these areas. Fibrosis would be there, atrophy would be there, and that confirms a diagnosis of the Sjogren syndrome. Whenever you have a fibrosis or atrophy of these glands, as well as the infiltration of the lymphocytes and formation of these terminal centers, you can have a diagnosis of the Sjogren syndrome, right? And yeah, so the oral thrush would be there, dental caries would be there, salivary gland infection would be there, right? Dry mouth would be there. That means failure to chew anything, dysphagia. Okay, dry eyes could be there, pain in the eyes, loss of salivation, loss of lacrimation. All these things are happening in the Sjogren syndrome. Okay, and yeah, that would be it. Any doubt?
No, thank you.
So that's all about the Sjogren syndrome. Okay, then comes the septic arthritis. Just like we have discussed the this gout, okay, which is the acute monoarthritis condition, you will have a similar presentation of the septic arthritis also. Okay, it would be a patient having a history of a severe type of joint pain, joint tenderness, swallowing, redness would be there. Okay, but the difference is that in case of the gout, you're having an inflammation because of the needles. Okay, sorry. Because of the monosodium urate crystals. In case of septic arthritis, it is because of the sepsis of the bacteria that lodges in the joint space and causing the inflammation there. Please note that the most common causative agent is the Neisseria gonorrhea. If you guys remember, whenever the gonorrhea becomes systemic, it can cause a sepsis, and after that, it can cause the septic arthritis. Okay, and you call them the gonococcal septic arthritis. Okay, the cause of the non-gonococcal septic arthritis includes the Staphylococcus aureus mainly and the Streptococcus. Okay, presentation will be similar to that of gout, but the WBC count will be more than 50,000. Systemic signs and symptoms of the inflammation would be there, like the fever, right? And because it is a septic arthritis, the history of sepsis would be there. Okay, which means the low blood pressure, high heart rate. Okay, these things are also there, right? And on the aspiration of the joint fluid, okay, uh, uh, in case of the gout, what we'll find are the needle shift crystals. In case of the septic arthritis, first of all, it would be a very purulent type of joint fluid. When you aspirate it, okay, you will find this smell, which is very much purulent. Okay, and when you do the biopsy or the microscopy of this joint fluid, what you will find is in numerous neutrophils which are phagocytosing these bacterias. Okay, gram negative bacteria or the gram positive bacteria would be there along with lots of neutrophils, and that confirms the diagnosis of the septic arthritis. Multiple joint involvements could be there. Okay, tendon involvement would be there, which is presented with the tenosynovitis. Dermatitis would be there, and please note it is a vesiculopustular type of rash. Vesicles would be there, pustules would be there, okay, which is a pus forming lesions all over the skin. Okay, so a pus forming lesions all over the skin. First thing, joint involvement. Second thing, acute joint pain. Third thing, fever. Fourth thing, and a history of sepsis. Whenever all these scenarios are present, you will always think about the septic arthritis. And please note, whenever a patient comes to your emergency department with a history of acute joint pain and no previous history of such type of a pain, because in case of gout, you will be having a history of a previous joint pain also, right? Because it is an episodic condition. But in case of this septic arthritis, it happens one time only, right? So the patient, they generally do not have any previous history of such kind of onset of symptoms, right? So whenever you encounter a patient with a history of joint pain, with the presentation of acute presentation of a joint pain, you will always want to give them the antibiotics first. You do not want to wait for the lab results. You do not want to wait for the this microscopy of the aspirate. Okay, as soon as you encounter the patient, you give them the antibacterial agent, antibiotic, right? And then you do the ESR of the patient, and then you do the this aspiration of the fluid only. Okay, and once you know that it is not a septic arthritis, it is a gout, then you can switch the patient to the NSAIDs or the other gout therapies, right? So that would be all about the septic arthritis. Any doubt in that?
Could you please repeat why we give antibiotics just when the person comes?
Because most commonly it could be also a case of septic arthritis, and you do not want the bacteria to be in the joints for more time, right? Because it is an acute bacterial inflammation, and once the joints are involved, okay, the nearby structures of the joint could also be involved, like the bones. Patient can also get the osteomyelitis, right?
Yeah.
And because of the sepsis, patient can also die.
Right.
Okay, so you do not want to wait for the lab results, right? You acutely want to treat the patient first. So give the antibiotics first, and then check for the ESR, check for these joint aspirate, whether joint aspirate is is very much purulent or not, whether WBC count is more than 50,000 or not, whether the bacteria are seen in the joint space or not. So first give the antibiotics, then do the these tests. Okay.
Okay, got it. Thank you.
And above the joint, this pain, if you're having this the vascular pustular kind of rashes all over the body, which means a pus forming vesicles all over the body, that means 100% is a case of septic arthritis. And it must be a case of gonococcal septic arthritis. Okay, and the patient generally have a history of sexual encounter also, a recent sexual encounter. Okay, and then the patient is having a joint pain and the rash all over the body. That means it is a gonococcal type of arthritis. If the patient is having a history of drug abusing, okay, or any kind of IV site, that means it could be a case of Staphylococcus aureus. Okay, a patient with a history of drug abuse, IV drug use, it could be a case of non-gonococcal septic arthritis, Staphylococcus aureus. Okay, and yeah, they do not have any kind of skin rash in case of Staph aureus. Skin rash only present in the gonococcal arthritis, right? So if the step 1 asks you what would be the sensitive test you can do, it would be a ESR, because in both gout as well as septic arthritis, you will be having an inflammation. That means a high ESR. So if the step 1 asks you what would be the next best step in management, it would be the give the patient antibiotic first. If they ask you what would be the sensitive test, it would be the ESR of the patient. What would be the specific test? It would be the synovial fluid analysis. You will check for the crystals, you will check for the bacteria, and accordingly we give the patient diagnosis, right?
Yeah.
Okay, so that would be everything about the septic arthritis. Any doubt on that?
No, thank you.
Okay, guys, I only have these slides up to this part, up to septic arthritis. Okay, actually, I'm still at my home. And
Yeah, no problem.
so, yeah, I don't have more slides for the continuation. So we will stop it here, okay?
Sure.
From tomorrow, we will have a full classes, okay? For full time, up to 9:30, okay?
Okay.
Okay, thank you.
Thank you so much.
Thank you so much.